Hello, everyone, and welcome to the June issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. We continue with our updated format, separating the surgical oncology and reconstruction portion of the journal into two 30-minute episodes. This episode, which we are calling Spotlight, will feature in-depth summaries and discussion on a few articles chosen by the feature editors. The second episode, Rapid Pearls, will cover the remainder of the journal, with the editors briefly covering clinical application of the data from each article. Our goal with this change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for June are Tara Jennings with Cooper University Hospital, who will be providing the article summaries, and Brad Merritt, Associate Professor of Dermatology at UNC Chapel Hill, who will be providing the expert commentary. Thank you for listening. We hope you continue to enjoy this new format, and as always, have a happy surgery day.
Welcome to this month's DermSurgery Digest podcast. My name is Tara Jennings. I'm a Mohs surgeon at Cooper University Hospital in New Jersey. And this month's featured expert is Dr. Bradley Merritt, who is a professor and director of Mohs surgery and cutaneous oncology at UNC Chapel Hill. We are so excited and thrilled that you're joining us this month. Thanks again for coming and doing this with us.
Yeah, thanks, Tara. We're really happy to be here. And these are some great articles to discuss. So looking forward to talking about them.
Perfect. So this episode will highlight surgical oncology and reconstructive articles from the June issue of Dermatologic Surgery. The first article that we will review is Updates for Management of Merkel Cell Carcinoma of the Head and Neck, a Systematic Review, by first author Kelly Kimball and senior author Kathleen Niemer. So as we know, Merkel cell carcinoma of the head and neck remains a rare but highly aggressive skin cancer with increasing incidence and significant mortality. In this systematic review, Kimball and colleagues evaluated recent advances in management by analyzing 30 retrospective studies, including over 16,000 patients with head and neck Merkel cell carcinoma. Surgery remained the foundation treatment used in 87% of patients, most commonly with wide local excision or Mohs surgery. Adjuvant radiation was used in 38% of patients and was associated with improved outcomes in several studies, particularly for high-risk tumors in patients with nodal disease. While the data were mixed, radiation consistently demonstrated improved local control. A major update from prior reviews was the expanding role of Mohs surgery. Several studies suggested Mohs may provide equivalent or even improved outcomes compared with wide local excision, while preserving tissue in cosmetically and functionally sensitive areas of the head and neck. Emerging immunotherapies, including checkpoint inhibitors such as avelumab and pembrolizumab, show promise but require further study. So Dr. Merritt, how do you currently manage a new head and neck Merkel cell carcinoma patient in your practice? Kind of what's like your checklist that you go through?
I think probably as with all Mohs surgeons, there might be some selection bias in the cases we're seeing, similar to how melanoma cases come into clinic. So usually we're going to be treating, on average, probably the less than stage 2, so the
Sure.
1 centimeter, 1.5, although bigger lesions show up, and certainly Mohs surgeons have treated larger. So I'm not saying we shouldn't be treating larger Merkel cell tumors, but they'll come to us from a variety of places, and usually we'll coordinate with surgical oncology to do a sentinel lymph node biopsy because it's just so critical. Even in the studies that show survival benefit with Mohs surgery is really that nodal staging is so important, because if you have subclinical nodal disease, as compared to melanomas, where it's unclear whether subclinical, that nodal disease that's microscopic might not be as meaningful all the time. I think with Merkel cell, we definitely see more direct impact on patient outcome if there is a positive node with subclinical disease. So we'll have the sentinel node biopsy done at least a couple of days before Mohs surgery, and then do Mohs surgery. And this is a big point made in all the articles, is even in the NCCN guidelines, try to keep things smaller because linear closure, so that if they need to go to radiation, and that is, I think, the biggest point of this article is, still the unanswered question of when do we send patients for radiation after Mohs surgery, or wide local excision if they have that. And but yeah, usually that's how we'll manage it, as sentinel node biopsy first, then Mohs surgery for the primary, and clear margin.
Yeah, absolutely. And on that radiation note, I think that one of the key takeaways from this article is that adjuvant radiation improves kind of this local and regional control and may improve survival in the higher risk patients, but survival data is really kind of inconsistent. What are your overall thoughts on adjuvant radiation?
same. And I've had many patients over the years that it's a very informed, it depends on the patient age. It's a very informed kind of conversation about radiation is not without its risks for sure. And I think sometimes they're undersold to patients. And, I mean, we have great radiation oncology colleagues, but most of the time, if we have a patient see the radiation oncologist, they're going to, move forward with, I mean, based on NCCN guidelines, because this is really, I mean, this article focuses on head and neck Merkel cell.
Yeah.
So you already have that risk factor, that poor outcome risk factor built into the treatment algorithm because it's head and neck. So I think it's a little difficult when you're in an academic setting to say, okay, we're going to fly maybe a little bit outside of the NCCN guideline. But if you have a young patient, radiation, 20, 30 years potential for the rest of their life to live with the outcome of radiation, and they have a less than centimeter tumor, and you have excellent margin control, there are studies that show, as we saw in this manuscript, that the outcome may not be any different if you get a clear margin and spare them from radiation. So I think it shouldn't be just, we're physicians before anything else, so it shouldn't just be surgery, then radiation. It really is, it has to be a balanced patient to patient conversation rather than just pulling the radiation trigger immediately.
Yeah, I completely agree
tumor,
with you.
We've all been there where it's like, I don't know about this margin. It's a super complex anatomic site, maybe like in the medial orbit or down in the ear, or, something where you just, I mean, most of the time we like to say, wow, we feel 100% certain about our margin. But realistically speaking, there are times where things get kind of so difficult that you feel confident, but your confidence starts to drop. And I think that's where you really need to be careful about assuming your margin is definitively clear.
Yeah, I completely agree with you. And at our institution, it really is a multidisciplinary approach and discussion about about everything with the patient, but really the radiation part is what we spend a lot of time on, discussing the advantages and possible risks with it. So I completely agree with everything that you said. And then lastly, are you doing or managing any Merkel cell titers or the cell-free DNA at your institution?
We don't, but if the medical oncologists are involved, and we're seeing, this study didn't really focus on, checkpoint therapy, but I've seen a lot of patients who are not surgical candidates over the years that have been, basically saved by pembrolizumab and some of the other, you know, immune therapies for Merkel cell. So that they'll, circulating tumor DNA is way better, I think, now than the polyomavirus DNA, because it's 50% of tumors are not going to express that. So it's not as, and I think even in the NCCN guidelines, they recommend circulating tumor DNA as part of the algorithm and workup. Yeah. And I think it's interesting along those lines that they mentioned the paper that says following the NCCN guidelines led to better outcomes in patients. So I would encourage listeners to at least be really familiar with those guidelines. And if you deviate from them, you just have to know you are deviating from them and what the reason is.
Yeah, absolutely. I totally agree with you. All right, moving on to our next one, the CLASS project, a proof of concept machine learning driven complexity level algorithm for surgical scheduling in Mohs micrographic surgery by first author Jorge Reyes-Duarte and senior author Nahid Vidal. So as Mohs micrographic surgery continues to grow in complexity, optimizing scheduling and workflow has become increasingly important. In the CLASS project, Reyes-Duarte and colleagues evaluated whether machine learning could predict Mohs case complexity and help in surgical scheduling. The authors analyzed over 20,000 Mohs cases across multiple Mayo Clinic practices and trained machine learning models using information as available at the time of referral, including patient age, sex, tumor diagnosis, and anatomic location. Complexity was defined by two major factors: number of Mohs stages required and need for complex reconstruction. The model performed particularly well in predicting complex reconstruction with an AUC of 0.83, while prediction of Mohs stages was more challenging with an AUC of 0.63. And remember, for these models, 1 is equal to a perfect model with 100% predictive accuracy. So the prediction of complex reconstruction fell in like the excellent discrimination category for this model, but Mohs stages fell in the poor to acceptable discrimination category. Anatomic location was the strongest predictor of complexity, with the tumors of the nose, lip, eyelid, and anogenital region associated with more stages, more complex repairs, and longer surgical times. Using these findings, the authors developed a Mohs complexity grade and smart scheduling logic to better allocate operative time and resources. So, Dr. Merritt, do you feel like this machine learning tool is something that you could incorporate into your practice in the future? And how do you currently schedule your day? Do you have any pearls for our listeners in improving efficiency and productivity when it comes to scheduling?
I really love your questions, and it's interesting. Like we came up with very similar kind of approach to how we schedule. We didn't have really machine learning. This was 2010 or 11. We affectionately called this system Squamous Eddie because it was a person's face and he looked like somebody who could be named Eddie. And we came up with a point system for because all the things that the machine learning, the conclusions. I mean, yes, for sure, I agree with that. IHC increases the time in most practices significantly, actually. And if you're treating EMPD, yeah, you need to take up 3 or more appointment slots. So yeah, we have a point system that we've used for years. I think the challenge is our schedulers adopting it or liking it or using it or understanding it.
Yeah.
So I could imagine a world where schedulers work with this but there's some gestalt in how you schedule. You look at a picture, like for example, we're meeting an hour later than we were scheduled to because of the 11:30 3 centimeter basal cell on the 40-year-old's lip that you like, oh, I didn't see this picture.
Yeah.
And the screening sort of fell through. And, maybe machine learning would have picked that up and said, don't do this because it's going to you're going to be an hour late to your, scheduled meeting. The only criticism I'll say about what they included are consults and follow-ups
Yep.
can just kill our schedule in the afternoon, at least for me. And you go and you end up spending an hour talking to somebody while you're waiting to do a few repairs for patients who are clear. That wasn't built into this, and I think for me, that's a huge problem. The other thing that I'll say is this paper is great for focusing on like a very tangible thing you can look through the chart for. Soft things that we all struggle with as Mohs surgeons. Are we staffed adequately? Do we have enough rooms? Are we having people help us with things like anesthesia, numbing? Because if you're doing all your own numbing, which for the first 12 years of my practice, I numbed every single thing I ever did. And that also is a huge time sink. So I think this is really great to look at how do we tweak the scheduling, but I think we have to add all of the other things in there. The other line that I loved in the paper was inefficiencies in EHR. And before machine learning schedules for me, I would love for it just to do all my notes, all my callbacks,
Totally.
all my billing. Why can't it not do that? That's where we need to that time chunk of whatever an hour a day needs to be eliminated first. But I really appreciate the paper and their the effort to make our schedules better. I think it's great. It's a great effort, and I enjoyed reading. I like just looking at the details of the breakdown of the cases. It was good of them to share that for the rest of us to look at, like, oh, how many EMPDs are you treating and how many weird tumors, and the 1.4 stages per case average is really nice to share because it helps you see a framework for a really highly esteemed academic Mohs practice.
Sure. Yeah, no, I completely agree with you there too. I think that it was a really interesting paper to read, and I'm looking forward to see what happens with this machine learning in the future. I do Mohs for melanoma at our institution, and I know that using IHC can be definitely a schedule breaker. Do you do any IHC at your practice, and how do you kind of work that into your day in terms of your scheduling?
Yeah, probably. I think their percentage was a little lower than what we do, than what I do. We did 2 out of our 9 cases today were melanomas. And so, and if you have something like an EMPD, as they mentioned in their text, that you have up to 30 or more blocks for, and they're small pieces that take the lab a long time to work on and get right.
Yeah.
And we all know treating EMPD that if you miss 1 or 2 cells, the thing's going to come back.
Yep.
So yeah, you have to be careful. Over the years, we've learned, like, don't put your IHC case first because if you have a small lab, it's going to bog your lab down unless you have an automated stainer, immunostainer. And so usually schedule something that's standard H&E first and then get into your IHC. Today, that did not happen, which maybe is another reason that I'm an hour late, is the 2 melanoma. We're a little short staffed in our lab right now. And 2 melanomas to start the day really kind of slows things down.
Yeah, definitely. All right, moving on to our next one. So pharmacologic methods to reduce postoperative bleeding during the first stage of interpolated forehead flap repair, a systematic review by first author Stephanie Matthews and senior author Stan Tolkachev. So the interpolated forehead flap remains the gold standard for reconstruction of complex nasal defects, but postoperative bleeding from the exposed pedicle after the first stage is the most common complication. Matthews and colleagues performed a systematic review evaluating pharmacologic strategies to minimize bleeding while preserving flap vascularity. The authors identified 9 techniques described in the literature, including hydrophilic polymer with potassium ferrate, ferric subsulfate, oxidized regenerated cellulose gauze, gelatin sponges, thrombin-based agents, aluminum chloride, cyanoacrylate adhesive, skin grafting, and tranexamic acid. Each technique works through a different mechanism, ranging from mechanical tamponade to enhancement of clot formation. The authors note that the choice of hemostatic strategy should be individualized. TXA may be particularly useful for patients on anticoagulants or antiplatelet medications, while cyanoacrylate or skin grafting may simplify postoperative wound care in patients who have difficulty managing dressing changes. And surgeons must balance improved hemostasis with the need to protect the vascular integrity of the flap. So, Dr. Merritt, what is your kind of, gold standard method in your practice for hemostasis in your interpolated flaps?
Oh, oh, I like all these methods. I think this paper reminds me of all the times I've heard people say, anytime you see 5 options for something, that means none of them are really
Yeah.
perfect. So, we've all been there where you get called at 8 p.m. or 10 p.m. or 1 a.m. or 2, when your patient's bleeding from often the most proximal portion of right at the eyebrow. So I think all these can be helpful. I think what I've learned over the years is make sure your patient's blood pressure is not elevated. If there's a lot of oozing during the case, you might want to check and make sure. And then also obviously outside of scope of what they're talking about, but for me, like really careful hemostasis with cautery on those small vessels at the edges makes a big difference. And then, yeah, I think having, tried most of these things, they all can work and be helpful. If someone's blood pressure's up high, I think it's going to be difficult. Now we use TXA pretty regularly, both topically. Usually in this case, we would soak gauze topically and just wrap it loosely around the pedicle, leave it for a bit. If someone's really bleeding, then dilute it with some lidocaine and inject the TXA straight into it. And there's papers looking at that too, and no risk of loss, with an appropriate dose. And then you don't want to constrict the pedicle, but I think good bandaging is still really, really important for these. So, but when I started at UNC, our facial plastic surgeons, they would always put a split thickness graft on the back.
Yep.
So that gave me the idea that I'm going to suture. I used to suture when we had porcine xenografts, and they were only like $70 per graft. I would suture those grafts in the back. And now, now the substitutes are too expensive, I think, for that to be justified. But I don't know. How about you? What do you like to do?
Yeah, I mean, I've tried. I haven't done the TXA directly into the pedicle yet. I still am a little nervous to do that, but I've done the tissue glue before, which I think has been helpful in particular patients. What I've learned, I've learned to kind of bring them back to take that tissue glue off and really clean it well after 1 or 2 days, and then maybe reapply it if they need to. I think that the tissue glue, I had one infection that scared me of leaving it on for like a week. And so now I bring them back after 1 to 3 days just to take it off, make sure that everything is nice and clean, and kind of teach them how to dress it. So that's been good. And then careful cautery. But yeah, mostly the tissue glue, careful cautery. I haven't done the TXA soaked gauze, but maybe I'll try that one.
It seems to help. I mean, we've seen a lot, I think, in general, like all the wounds that tend to ooze, like second intention before they go home on the scalp, and somebody's really bleeding a lot. Ear things that are hard to bandage, but
yeah, no, definitely. And do you alter your approach at all for anticoagulated patients, or is that, it just kind of is how much they're bleeding during the procedure?
Yeah, I think they mentioned this in the paper, right? 40% of our patients are anticoagulated, and maybe it's higher than that. I've learned. And I think there are previous studies from years back that show you can't really tell surgically who is and who isn't anticoagulated. I don't alter that. It's address the bleeding as you see it, and as you do develop maybe a little bit of a sixth sense for, I think this is going to bleed later. Maybe skin type, or people who have rosacea, or other just sort of the reddish hue to the skin in general. You just know that, or they have a history of bleeding after surgery.
Yeah,
Just be extra careful.
definitely. All right. Well, thank you for your insights. That wraps up our spotlight episode, and we want all of our listeners to join us for the Pearls episode coming up. So thanks, Dr. Merritt, for joining us.
Thank you for having me.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.